Ready?
Mhm.
All right. We're on.
Okay. My name is Kaylee Dorsey. I am the Emergency Department and Trauma Clinical Educator at Mercy Hospital in Joplin. And I'm going to be going over recognizing and managing CHF patients in the field. So I want you guys to consider CHF and think of it like a sump pump that's in your basement that you can't keep up with during a storm. That's ultimately what it is. CHF's definition is the heart's inability to pump blood effectively to meet the body's needs. This then results in the fluid backup into the lungs, which is left-sided heart failure, or systemic circulation, which is right-sided heart failure. You're going to see these in patients that have cardiac injury or strain, decreased cardiac output, neurohormonal activation, fluid retention, which leads to congestion worsening, pump failure. And I have a picture up there for specifically what a normal heart looks like and then what a heart failure heart looks like. The patients do present often with swelling in their legs and edema in their feet, and then show excess fluid around their lungs, which results in them verbalizing their shortness of breath. Why does CHF matter in EMS? EMS is often the first point of care and encounter for these patients during an acute decompensation, and this can alter the outcomes by early recognition and rapid intervention on your guys' end. CHF is not a single event by any means. It is a chronic disease process with acute exacerbations that often usually occur in older adults, but they can actually occur at any age. We're seeing it in younger and younger patients as cardiac disease advances, especially post-COVID. So CHF is actually the only time that we are more worried about the lungs than the heart. Common triggers for CHF is medication and diet noncompliance, such as not taking their diuretics, excessive fluid intake, and salt intake. AFib patients are more at risk, or any patients that experience dysrhythmias or have history of MI. Uncontrolled hypertension is huge in CHF, and infections such as sepsis, pulmonary embolisms, and renal failure patients due to the fluid off shift. So I want to emphasize something that I always emphasize, whether it's outside a hospital or inside. You've got to treat your patient, not just the numbers. A patient can sat 98% until they don't. If your patient is verbalizing that they are significantly short of breath, if they appear short of breath, it's only a matter of time before the oxygen saturations mimic what they are showing you. If they can cuss you out, though, they probably aren't that short of breath. The key here is appearance and speech patterns, such as speaking in full sentences, can tell you a lot about the severity of their shortness of breath. A rapid but thorough assessment is needed in these patients. CHF can mimic COPD, asthma, even pneumonia, but you need to be able to differentiate based on those basic clues. Assessment looks like for airway, dyspnea, having a cough. Do they have pink frothy sputum? We'll get to that and what that means in a couple slides. Are they tachypnic? Do they have crackles or rails on their lung sounds? How is their circulation? Are they tachycardic? Hypertensive is an early sign, and then hypotension is when we're a little late to the party. Do they have JVD or peripheral edema present? Sometimes they're cool and clammy, which is equal to poor perfusion. And then asking about history. Do they have a CHF diagnosis? A lot of people say, well, I've been told that, but never really diagnosed with it. So then you can go further, like, do you take Lasix or Bumex or, any type of diuretic or beta blocker? And that'll kind of give you some clues as far as what you're working with those patients, because not everybody is the greatest historian these days. Here's just some visual images because some people will remember it better. The first picture is of pitting edema. I guarantee you, if you have picked up any patient in the area, you have probably seen this at least once. And then the second picture is the potential flash pulmonary edema and pink frothy sputum in the airway. And then the last picture is of jugular vein. That is a very prominent sign of emergency care indicated. So some red flags that you guys need to be aware of with these patients is severe respiratory distress, hypoxia, pink frothy sputum or pulmonary edema, altered mental status, and hypotension with poor perfusion. So when you arrive and see pink frothy sputum or fluid bubbling in the airway, you're live witnessing real pulmonary flooding. Suctioning is indicated if the airway is being compromised, and it buys you time by improving ventilation, but it is not the main weapon in this fight. Patient will still need CPAP, potentially vasodilators, and afterload reduction. Sit them in a really straight upright position, get good monitoring, and then rapid transport. Think of suctioning as enabling their ventilation, not fixing the pump failure. Also be aware that suctioning itself can cause desaturation or hemodynamic shifts in a fragile cardiac patient, so work swiftly but purposeful. Some pre-hospital interventions that I feel are important to mention is oxygenation, so titrating your oxygen and avoiding hypoxia in these patients. Be mindful as well, though, that COPD patients aren't generally satting at the same percentage with those with healthier lungs. So by no means am I saying, hey, the patient's on 3 liters at home, 15 liters should fix it faster, right? Oxygen titration is essential, meaning more isn't always better for them, especially in that COPD overlap. Nitroglycerin causes vasodilation, so you can do the sublingual every 5 minutes as tolerated, times 3 doses is our protocol at Mercy. I don't know what your guys' protocol is. It's important to be mindful of your protocols for these patients. Not a bad idea before acute respiratory season, since the weather has changed, to take a look at them. IV nitro and starting a drip on them is also very beneficial, as your protocol allows. Some have protocols as far as giving diuretics en route, such as Lasix. Sometimes, though, it is controversial for pre-hospital use. IV access, monitor, get a 12 lead. If the patient's hypotensive, though, first line, you've got to be really cautious with IV fluid boluses in these patients. 250 mLs at a time is not a bad idea, and then reassess your lung sounds and your blood pressure, but you want to avoid large volume resuscitation because it can significantly worsen pulmonary edema. Pressors rarely are initiated in pre-hospital treatment, but if you've got like a long hospital or a long trip to the hospital, it's not a bad idea. Be mindful that although it looks similar to signs of dehydration, your CHF and dehydration are not equivalent to each other. The difference between hypotension from pump failure versus volume loss is critical in that of a CHF patient. So I want to stress that we definitely want to avoid the instinct that we always have of just run a leader in. So I know that's our go-to when our pressure is low, but you can actually worsen your patient by doing such. And I've got a case scenario for you, just something to jog your brain a little bit. 72-year-old male, severe shortness of breath. You arrive and he's in the tripod position. His O2 saturation is 84% on room air. You note frothy sputum. Got a heart rate of 120, a blood pressure of 190 over 100. Your respirations are 32, and you've got crackles throughout. What's your first move? You've got some intercostal retractions noted as well. He appears like he's most likely a COPDer at baseline, probably has some CHF. But with that, O2 sat, high blood pressure. Yep, CPAP and nitro, because you're most likely dealing with flash pulmonary edema. Nitro paste is always a great bet with a flash pulmonary edema. Another case scenario, 68-year-old female, short of breath. She's got crackles present on her lung sounds. Her O2 sat is 82%. Blood pressure is now 78 over 50 on your arrival. She's cool and clammy. What's your move? You want to consider oxygen support. It looks like she's already on some at baseline. And then fluids. Your first line is going to be a cautious bolus, such as that 250 that I mentioned, and then rapid transport. You can consider a CPAP, but only if your blood pressure will tolerate it. Something I want to mention is sometimes these patients can't tolerate CPAP, so you most likely want to intubate them if it's necessary. But we need to talk about why the crash post-RSI, because whenever you do RSI, you take that sympathetic drive away and their parasympathetic system is overloaded. So these patients are using every ounce of their catecholamine or adrenaline to stay alive. When you sedate and intubate or paralyze them, you take away that drive, and then the heart suddenly has no more gas pedal. One, you need to optimize the oxygen first. Don't rush your tube. These patients are short of breath most of the time at baseline, and although they're significantly short of breath right now, it doesn't necessarily mean that they can't compensate a little bit longer while you pre-oxygenate them. Know your baselines. Like I just said, your patient is short of breath at baseline. Do they normally sat 84% instead of 82? Are they an 89%er? It's not uncommon for these COPD and CHF patients to not sat above 90%. Choose your drugs wisely. In CHF patients, ketamine is your friend. Fluid and pressor readiness, so maybe mix up some push dose epi so that it's available to you whenever this patient's tank after their RSI. Just some pearl points. CPAP does save lives if you use it early, if the blood pressure allows. Nitroglycerin is your friend in a hypertensive CHFer. Don't delay transport for an IV or meds if the patient is unstable. Hypotensive CHF, you treat very delicately with very small boluses and then reassess. Look for underlying causes in your patients, such as, are they having an MI? Do they have some sort of infection? Are we dealing with a dysrhythmia? Things like that. So decision tree here. If you've got a high blood pressure CHF patient, go ahead and utilize your CPAP and your nitro. If you've got a low blood pressure CHFer, just do cautious fluid boluses, avoid nitro, and transport really fast. CHF is an acute onset versus COPD being more gradual or progressive shortness of breath. COPD is more often noted with infection or irritation, and then CHF often overnight or very sudden. They differentiate history-wise, such as a long smoking history, emphysema, or chronic bronchitis with those COPD population patients. And CHF, they can have a history of heart failure, carotid artery disease, hypertension, take medications like Lasix or beta blockers. On exam, you're going to find a difference in the lung sounds. CHF usually has crackles or rales. Sometimes they do have that frothy pink sputum noted, JVD, and they have edema in their lower extremities. COPDers usually are wheezing with diminished breath sounds. They've got that barrel chest and then pursed lip breathing. Vitals in CHFers are very prominent most of the time, such as very hypertensive, tachycardic, and hypoxic, whereas COPD, they may be normotensive, but hypoxic and hypercapnic. CHF patient response would be CPAP and then nitro to usually improve that, and then nebulizers and steroid treatments. Not nitro is good for COPD.
Thank you.
Is it? Oh,
You can reposition or even set it on the table, whatever works for you.
okay. Do you feel like they could hear me if
They're hearing some sort of,
it's
I think
probably
it's your name tag,
that name tag?
or your collar there or something. So we're just trying to
Yeah.
fix that. So thank you.
Sorry about that.
No, you're fine.
CHF can also present somewhat like pneumonia, but pneumonia, you're going to have more of a fever, chills with a productive cough, and maybe some yellow or green sputum, a history of a recent illness. They're going to complain of that pleuritic chest pain, localizing that lung involvement. Whereas CHFers, it's still the acute, overnight, or sudden onset with the history. CHF patients don't generally run a fever. And then treatment for pneumonia is differentiated by the need for antibiotics in the hospital. They don't necessarily require CPAP or nitro. I just went back instead of forward. CHF is rales and crackles dominating the lung sounds, mostly older age generation with a cardiac history, frothy sputum, orthopnea, JVD, peripheral edema, often hypertensive with that fluid overload, whereas asthma patients experience that wheezing, prolonged expiratory phase, usually younger generation, history of asthma and allergies, clear sputum is present, no JVD or pedal edema, primarily with the asthma population. Now, they can have status asthmaticus where they are just as sick as a CHF patient, but it is treated a little differently. Such as bronchodilators and steroids. I do know that we dump MAG in the status asthmaticus patients in the hospital setting. I am unsure of what your guys' protocol is.
If they're sick enough, of course, we would start with dual nibs.
Yes.
If that doesn't seem to work, or it's refractory to that and that kind of thing, magnesium on the list.
Because of that bronchodilation. Yes, it is.
Also relax those bronchioles.
Yes, it is very, very prominent treatment in our status asthmaticus, and you can see them change like immediately. So it's very beneficial to them.
First line.
Yes.
Yeah.
MAG. Yeah. They present tachypnic, tachycardic, and may progress if very severe. Before I get into this, though, I do want to mention the PNA is currently, with us nursing instructors and educators are, I guess, I don't know if you would call it blogging or messaging back and forth on a forum about respiratory season readiness, and because there's a nationwide movement right now for pediatric readiness. This is supposed to be the worst pediatric respiratory season we've seen in years. So
we keep saying that too.
Those asthma kiddos. Well, we've already intubated, I think, 6 pediatrics in the last month or two in the hospital setting and had severe respiratory distress. We're seeing a lot of human rhinovirus and stuff like that in our peds population right now. So we're trying to get ready for that. But a lot of little kids have untreated or undertreated asthma. So it's just something I felt like worth mentioning at least.
Yeah.
They're talking about it going to be pretty rough for this cold change season. So we'll move on to CHF versus flash pulmonary edema, which they are now calling acute decompensated CHF. Pink frothy sputum in a decompensated heart failure or pulmonary edema patient is a huge red flag. The lungs are flooded and the alveoli are now filled with fluid or an air mixture of fluid. And then some of the alveolar lining, including the surfactant and producing cells, may be damaged in this process. So biomarkers are showing evidence of that. And suctioning is not primarily about removing the surfactant to preserve it or leaving the froth to maintain that surfactant. The priority is clearing the airway so that you can ventilate and oxygenate the patient. Some of the froth might include disrupted surfactant or lining fluid, but we don't treat it as a beneficial substance. The patient is still crashing and needs ventilation and decongestion. There has been research into surfactant protein biomarkers in pulmonary edema, which shows alveolar injury. While that doesn't change our immediate EMS approach, it highlights how severe this process actually is. Yes, suction the airway if the patient is producing copious frothy sputum and ventilation is impaired. But remember, suctioning is a tool, not the primary therapy. Don't let suctioning distract you from the big ticket interventions, such as upright interventions, CPAP, nitrates, vasodilators, if allowed, oxygen, and then rapid transport. And if the patient's blood pressure is low and their GCS is dropping or ventilation is failing, don't waste your time. Secure the airway and ventilate first. Flash pulmonary edema is even more of a sudden onset than CHF, and it's often triggered by acute MI, severe hypertension, arrhythmia, or valve rupture. Patients literally look like they're drowning in their own secretions, and that's how they describe how they are feeling. Severe dyspnea, extreme anxiety, they get really diaphoretic. They got large chests most of the time, with lung sounds being very diffuse and loud crackles are heard. Very, very hypotensive most of the time, and then they can crash, becoming very hypotensive when they go into cardiogenic shock. If you can, do immediate CPAP and then give them some nitro. Again, if their blood pressure tolerates, that's going to be the best line of treatment with these patients. They have a very high risk of deterioration, so priority 1, rapid transport is a must in these patients. So whenever you are reporting off, I know that we are utilizing Pulsera. We're trying to get used to it in the ED at Joplin with all of the changes and everything. But if you need to call report because you can't take the time to type, that's absolutely appropriate. We know most of you, I feel like, and know your tone. And if your tone is off or you're excited or, a little trembling in your voice, we know that it is a legitimate call. And we also can tell when you're unimpressed. So just whenever you're giving handoff to us, just a clear, concise report of when the symptoms occurred, such as onset, your interventions, and if they responded to your interventions, any pertinent history such as Lasix, non-compliance or compliance, any prior episodes of this, and what your basic impression on your exam was. Interventions provided, if they responded to your nitro or CPAP, what their vitals have been trending. It is very important with patients if they have any hypotensive or hypoxic episodes. And then your EKG findings. Do they have some ST elevation? Because an MI can absolutely cause them to go into heart failure. And what your suspected causes are. Whenever you are giving report, and you arrive to the hospital in the ER room, you have the room, and please let someone know, whether it's leadership there, myself as the educator, or in a trauma situation, our trauma coordinator, because we have a huge value of our relationship with you guys and outlying EMS services. And so it's very important to us that we maintain that relationship and we make sure that our staff are being appropriate in these situations and treating you with the dignity and respect that you guys deserve. I simply could not do what you guys do. I think that I'm perfectly comfortable where I am, surrounded by all of the equipment that I have at my fingertips. And when I'm out of ideas, I have a doctor that I can ask what to do next. So I have mad respect for everything that you guys do. And I hope that we are being appropriate whenever we're taking report.
That goes both ways. Can't speak for Kyle, but if our guys are not also reciprocal in that respect, let me know.
Yeah, no, for sure.
You do what?
I get along with Kaylee, okay?
Yes.
We get along.
Yeah, right.
Yes.
That's
excellent. Pitfalls to avoid in these patients. Over oxygenating, kind of like I mentioned earlier with those COPD patients, it can actually make them more delirious and confused. Missing the alternative diagnoses, I can't even talk today. Diagnoses such as COPD, asthma, and pneumonia patients. Don't forget to reassess your response to interventions. If you give a patient nitro and you're not monitoring their blood pressure closely, you can cause some significant harm. Special considerations in populations would be those with renal failure because they often are in fluid overload. Patients with pacemakers or LVADs, they have a unique perfusion assessment to be mindful of. And elderly patients, they're very sensitive to those preload, afterload changes. And then CPAP compliance. You got to reassure and coach them because not everybody can feel like they're being suffocated and tolerate it well. It's crucial with these patients in severe distress to be able to identify those who may worsen with that preload reduction. Not every patient can handle medications or treatments that lower the amount of blood returning to their heart is going to cause. And then some heart failure patients rely on that extra blood flow to keep their pressure up. So if we give nitro or use CPAP on someone whose blood pressure is already low, we can actually make them crash. That's why we always check blood pressure and watch how the patient responds before or after giving any nitro or starting them on CPAP. Recognizing early is the key so that you can intervene early and create better outcomes for these patients. Oxygenation and positioning and CPAP are all very powerful. Nitro is utilized wisely, and it can be very helpful when it is. Avoid unnecessary fluids, so you need to think it's a pressure problem, not a fluid problem. And then strong communication also leads to better outcomes. And EMS plays a vital role in reducing the mortality and readmission rates for the hospital. Then I always try to open up the table for any questions, anything that I can assist with, or anything I didn't educate on these patients that anyone has any
Questions about?
question. Yeah.
Todd, any questions?
Nope,
They're
they're good.
They're 10, 15 seconds behind us in that typical streaming delay, so it may take them a moment to kind of catch up to where we are.
Okay.
So we'll just kind of let it sit for a minute. This is usually when they'll throw out questions. They got to type them in the comment section. So it's interactive, but not as necessarily real time interactive.
Right.
Pretty darn close, but
I wonder if oral neck sulfate would be helpful for severe asthmatics at like nighttime. Go to bed.
I don't know. It's like a fine line. You've got to be so careful with magnesium because of the dysrhythmia risk.
magnesium, daily use of magnesium has some side effects. And
Yeah.
I don't know what kind. There's like 7 or 8 different kinds.
There
My
are.
wife takes it for her leg cramps.
Night cramps
So
are
it's
great.
just like,
Yes.
why wouldn't an asthmatic take about the same
I actually
amount at
do.
night? Maybe to,
I have asthma and I take it every day. I take a L-theronate.
Mm-hmm.
It doesn't have some of the other side effects. It actually does seem to help. I'm less dependent on my asthma control medicine.
Yeah, there's a lot of research going on right now too about the GLP-1 because it's an anti-inflammatory and it's actually helping COPDers and asthmatics, basically taking away that lung inflammation.
There's like wonder drugs. Every time they turn around, there's something else new.
Something else. I know it is always.
It's like we should all just be on. Just put them in the drinking
I
water.
can tell you this, my sister is on it and she won't get off of it. She looks like a skeleton.
Questions?
I did. I think I'm getting that response. So excellent information. Thank you. Thank you. Thank you so much. Thank you very much. I haven't had any questions yet. So. Okay, Kaylee, I don't know that there's
Well,
any questions that have come through yet. So.
last thing, I really, really hope to see a lot of you come to the
Trauma
conference. We have Scott Lyle. He usually does speak at Guardians. He's our main speaker this year at the Joplin conference. I have the fire chief from Stillwater coming to talk about their disaster response with the wildfire and how they triaged. We've got some really good speakers lined up. We've got some great door prizes like Yeti coolers and kayaks and camping chairs, bait and tackle gift certificates, things like that, tactical gear. And then, of course, the vendors always have great things to give out. So, yeah, this is my first year planning. So,
it's next Friday, November 7th.
November 7th at Missouri Southern from 8 to 5.
In the Billingsley Center? Or where?
Yes.
Yeah.
Mm-hmm. Yep, we'll be set up in there.
We have a TV message board that we use, and it's been on there for a while. I think I've sent an email too.
Mm-hmm.
I'll fire it off again and remind them.
That would be great. I would
Some
appreciate
of them get a little
it.
worried about the fee and like, oh, is that on me? Or I just need to. We can work through some of that stuff and probably send a few.
Yeah, no, that would be great. And if you need any help with that on our end, just let us know.
And there's a virtual option too.
There is. It is virtual if you don't even want to come in person.
Qualify for door prizes if you're virtual?
No.
Oh, see.
But you do get
yeah.
breakfast, lunch, and snacks if you
Virtual?
come in person.
You're going to have them DoorDash if they're virtual.
Breakfast, lunch, and snack.
Yeah.
All
You
right.
can have your own snacks at home.
You can get your own snacks and your families. Okay.
Yeah.
Yep. There hadn't been any questions, just more thank yous come through, Kaylee. So
All
appreciate
right. Well, thank you for the opportunity. I appreciate it very much.
it. We thank you very much. All right, everybody, we're going to sign out. And up next is pain
Pain
management.
management.
Yeah.